morning, ladies and gentlemen, and welcome to the Health Technology Assessment webinar. Before we begin, here a few housekeeping. If you experience technical difficulties, please refresh your browser by pressing F5. For additional technical guidance, click the Help widgets. For submit question during the session, use the Q&A widget. If a question requires a more detailed response or time runs short, we will follow up by email. Additional materials are available in the resource list widget. We will ask for your feedback at the end of the webinar and would appreciate your responses. Thank you and enjoy the session. Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera bagi kita semua. Salam Om Swastiastu, Namo Buddhaya, salam kebajikan. Good morning and welcome to the Health Technology Assessment webinar, From Policy to Practice, Navigating Indonesia's Evolving HTA Landscape. Selamat pagi dan selamat datang kepada seluruh partisipan, Bapak dan Ibu undangan yang kami hormati. Terima kasih telah berkenan hadir pada acara pagi ini. My name is Sita Maimunah and I am honored to be your master of ceremony for today's event. It is truly a pleasure to welcome each one of you to this webinar. This Health Technology Assessment webinar is held in commemorations of the 61st National Health Day. This event is organized by Health Policy Agency of the Ministry of Health Indonesia in collaboration with IQVIA. Bapak Ibu, webinar ini dirancang untuk mendorong translasi pengetahuan HTA dengan menyajikan perkembangan terkini dan prospek masa depan HTA dari ranah kebijakan menjadi layanan kesehatan yang berkualitas. Today, we will explore global HTA trends and innovation presented by IQVIA and updates on Indonesia's HTA policy from the Indonesian Health Technology Assessment Committee. This session will help us to understand the evolutions of HTA and its significance for the future of health innovation and equity in Indonesia. To begin with, please allow me to extend our warmest welcome to our honorable guest and speaker. Selamat pagi dan selamat datang kepada yang terhormat Direktur Jenderal Farmasi dan Alat Kesehatan, Director General of Pharmaceutical and Medical Devices Ministry of Health, Dr. Elriska Andalusia. Yang kami hormati Kepala Badan Kebijakan Pembangunan Kesehatan, Director General for Health Policy Agency, Profesor Asnawi Abdullah PhD, General Manager IQVIA Indonesia, Mr. Joel Takata, and our distinguished speaker, Dr. Panji Hadi Sumarto PhD and Sirin Pecara Pirak, Master of Science. Distinguished speakers, ladies and gentlemen, to kick off our webinar, we would like to invite the Director General of Pharmaceutical and Medical Devices Ministry of Health to deliver the welcome remarks. Kepada Ibu Dr. Elriska Andalusia, kami silakan.
Suaranya apa ini? Oh, teleponnya mati. Oh, kan telepon kamu di sini loh, matiin makanya.
Dr. Rizka, over to you. We can hear you.
Udah nyala. Halo. Hello,
Yeah,
good
Dr. Rizka, we
morning.
can hear you.
Oh, ya. Thank you. Ya. Assalamualaikum warahmatullahi wabarakatuh. Om Swastiastu, Namo Buddhaya, salam kebajikan, salam sehat untuk kita semua. Very good morning to our speaker and also team from IQVIA. and head of Minister of Health Policy Agency, Pak Prof. Asnawi, dan juga para peserta semuanya. Allow me to give the introduction in bahasa Indonesia. Puji syukur kita panjatkan kepada Tuhan yang Maha Kuasa karena atas karunia-Nya kita pada hari ini dapat berkumpul di sini untuk melakukan kegiatan yang sangat penting, yaitu workshop terkait dengan webinar terkait dengan Health Technology Assessment yang mengambil tema From Policy to Practice, Navigating Indonesia Evolving Health Technology Assessment Landscape. Merupakan suatu kesempatan yang sangat baik dan merupakan satu kehormatan buat saya untuk juga hadir di sini bersama Bapak Ibu sekalian. Dan karena apa? Karena Health Technology Assessment ini merupakan suatu kegiatan yang sangat penting yang harus dilakukan di rumah sakit dan di beberapa pelayanan kesehatan lainnya, serta di Kementerian Kesehatan. Tentunya kita menyadari bahwa perkembangan teknologi kesehatan, baik itu perkembangan vaksin, terapi, diagnostik, dan teknologi medis lainnya, termasuk juga robotik, kemudian artificial intelligence, ini sangat-sangat cepat sekali. Dan untuk memastikan bahwa setiap teknologi yang baru yang akan diterapkan dalam pelayanan kesehatan, kita perlu melakukan Health Technology Assessment, yang merupakan instrumen yang sudah disusun dan diakui secara internasional untuk melakukan assessment atau kajian terhadap suatu teknologi yang baru, apakah dia benar-benar cost efektif atau tidak. Apakah dia memberikan manfaat yang baik dan memberikan dampak yang positif terhadap pelayanan kesehatan yang sudah ada. Bapak Ibu yang saya hormati, Kementerian Kesehatan pun telah menerapkan hal tersebut dan ini sudah dikuatkan dalam peraturan pemerintah kita dalam dan juga dalam Undang-Undang 17 tahun 2023 bahwa kita berkomitmen untuk memperkuat sistem HTA. Termasuk juga dalam undang-undang atau peraturan presiden penerapan jaminan kesehatan masyarakat JKN, bahwa kita harus melakukan kajian HTA sebelum memasukkan pembiayaan dalam pembiayaan kesehatan. Nah, untuk itu tentunya penguatan dalam proses melaksanakan HTA ini menjadi sangat penting dan kritikal. Dan juga kita berupaya agar masyarakat kita memperoleh akses terhadap teknologi kesehatan yang berkualitas, tetapi dengan biaya yang seefektif mungkin. Nanti secara detail mungkin tahapan HTA dan metode-metode HTA bisa dibahas di sini. Tetapi harapan kami adalah bahwa pelaksanaan kajian HTA ini dilakukan dengan benar-benar terstruktur standar yang sesuai dengan standar internasional. Oleh karena itu, saya ucapkan terima kasih kepada IQVIA Team dan juga teman-teman semua dari BKPK maupun dari Pharma telah menyelenggarakan kegiatan ini untuk memperkuat tim HTA di Kementerian Kesehatan dalam mengambil keputusan kajian cost effectiveness suatu teknologi kesehatan yang baru. Demikian mungkin yang dapat saya sampaikan. Terima kasih. Wassalamualaikum warahmatullahi wabarakatuh.
Terima kasih Ibu Dr. Rizka Andalusia. Next, to officially commence the webinar and deliver the opening remarks, we would like to invite the Director General for Health Policy Agency for deliver his opening remarks. Please welcome Professor Asnawi Abdullah, PhD, to deliver his speech and officially open this webinar.
Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera, salam sehat untuk kita semua. Good morning, distinguished speakers, colleagues, participants, ladies and gentlemen. Let me start by sincerely expressing my appreciation to Dr. Rizka Andalusia, Director General of Pharmaceutical and Medical Devices, for her gracious welcome and for her leadership in advancing health innovation and technology assessment in Indonesia. I would also like to express my sincere gratitude to our esteemed speakers, Dr. Panji Fadi Sumarto, PhD, the member of Health Technology Assessment Committee, Ms. Sirin Petcharat, Principal Real of World Evidence at IQVIA Asia Pacific, for joining us in this important dialogue. My appreciation also goes to our moderator, Mr. Joel Takata, General Manager of IQVIA Indonesia, and for all participants representing government institution, healthcare provider, professional organization, academia, industry, and civil society. It is my great honor to officially open this webinar, From Policy to Practice, Navigating Indonesia Evolving Health Technology Assessment Landscape, which co-organized by the Ministry of Health and IQVIA. Over a decade has passed since Indonesia launched its National Health Insurance GKN in 2014, a transformative step toward universal health coverage. Since then, health technology assessment has become a cornerstone of our policy decision, guiding us to determine which medicine, which medical device, and which intervention provide the most value for our people and the most value for our health system. The World Health Organization defines health technology assessment as a systematic evaluation of the properties, effect, and the impact of health technology aimed at informing policy and decision-making. In our context, health technology assessment is more than a technical process. It represents a moral. It represents a strategic commitment to make our health policy that are scientifically sound, economically efficient, and social just. In October 2024, the Ministry of Health officially launched One Door, One Standard Health Technology Assessment Business Process. This reform marked a major milestone, unifying submission for pharmaceutical, diagnostic, medical devices under a single coordinated and transparent system. It established a clear standard, adapted methodologies, and faster review cycle that ensuring high-value technology reach patients more efficiently while maintaining scientific rigor and accountability. This initiative reflects our determination to align Indonesia health technology assessment framework with the global best practice, informed by consultation with the World Health Organization and by learning from leading health technology assessment agency in several countries, including Singapore, Australia, Malaysia, and Thailand. It is not just bureaucratic improvement. It is a structural commitment to a more sustainable and equitable health system. Over the past decades, Indonesia has made a substantial progress in institutionalized health technology assessment as key evidence-based policy instrument. Several of these recommendations have informed the National Formulary or FORNAS, or Guide Revision of clinical practice guideline (NPK), which contribute to tariff adjustment and even shape national health program. This achievement demonstrates that health technology assessment in Indonesia is no longer an academic exercise. It is now a policy enabler, directly influencing the design of benefit package under the National Health Insurance or GKN, and supporting the government broader commitment to efficient and equitable healthcare spending. As we look forward, three strategy directions will guide our effort. The first one is deepening cross-sector collaboration. Stronger partnership among government, academia, industry, and patient group will ensure that health technology assessment process reflect diverse perspective and national priority. The second effort is building methodological and analytical capacity. We must continue to refine our tool from economic modeling to real-world evidence generation to ensure assessment are timely, reliable, and relevant to Indonesia policy needs. The third effort is ensuring equity and sustainability. Every technology you assess should not only be cost-effective, but also improve access and the outcome, especially for most vulnerable. In the other words, health technology must help us answer not only can we afford this technology, but also can we afford not to. This theme of today's seminar, from policy to practice, captures a vital challenge on how to translate well-designed framework into real-world impact. Through today's dialogue, we will learn from IKEA global experience in health technology innovation and gain update from INA health technology assessment on Indonesia's evolving health technology landscape. I'm confident that the insight shared today will help us strengthen our collective understanding, foster collaboration, and move decisively toward a health system that is innovative, transparent, and evidence-driven. Once again, I extend my sincere gratitude to all our partners, especially IQVIA, for their collaboration and unwavering support. To all participants, thank you for being part of this important milestone. Therefore, I'm pleased to officially declare today's web seminar open. Thank you, and I wish everyone a productive and inspiring session ahead. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Terima kasih Profesor Asnawi Abdullah atas kata pembukaannya. Distinguished speakers, ladies and gentlemen, our webinar is now
Yang sebenarnya yang itu yang welcome remarks dari Dr. Rizka Indonesia sama yang opening remarks dari Prof. Sawi Abdullah. Mungkin dari kita IQVIA pasti di Kemenkes, di the Ministry of Health. Ya. Kita lihat di Jakarta, tapi ada yang audience dari keluar Jakarta. Terus saya mungkin yang also be speaking in English for this webinar. So again, we are very honored in IQVIA for this opportunity to work with the Ministry of Health. Indeed, the topic that we have today on HTA assessment especially focusing on policy, from policy to implementation is very timely. It's also joining side of Indonesia, which only goes to show the importance of this topic, and this topic becoming very relevant and timely. Us and IQVIA has been involved in supporting and moving healthcare forward. We are working, of course, in both in the clinical side and also in the commercial side. We have been working with the Ministry of Health here in Indonesia and across the different markets in terms of public health. And part, of course, of the public health discussion is the healthcare technology assessment. And it is in this context that we are very fortunate to be joined by esteemed colleagues and speaker for today. So let me just give a few introduction on our esteemed colleagues who will be discussing this HTA topic for today. We have Ms. Serene Petrara-Piruch from IQVIA, our managing principal for our real-world evidence and healthcare outcomes research in both Southeast Asia and Asia Pacific. She's currently based in Singapore, who was flown all the way from Bangkok, going to Jakarta. And Sirin has been passionate about this subject matter. He has worked in the industry and also currently a guest lecturer in the Chulalongkorn University in Bangkok. After Sirin's discussion, which is focusing more on the role of the healthcare technology assessment and also presenting us with cases across the different markets on the opportunities and challenges in HTA, we will also be presented immediately after by Professor Panji. Yeah, and again, we're very fortunate to be joined by Professor Panji, who has been actively teaching in the academe in the public health space, in the epidemiology space, and has been practicing in the HTA segment, working alongside with, of course, with the Ministry of Health and several stakeholders. So for our audience here in Indonesia and outside Indonesia, we encourage you to take some notes. We'll have a Q&A session later on, so please feel free to send us your questions. So without further ado, let me now turn over the session to our next speaker, Sirin Petra-Peruch. Sirin, over to you.
Thank you, Joel. Hi, good morning, everyone. My name is Sirin Petra-Peruch. I'm the managing principal from the IQVIA, from IQVIA Asia Pacific. It's also my pleasure to be here today and also part of the exciting journey and also as well as a critical milestone for the Indonesia HTA system. So in my session today, I will share with you some of the lessons learned from the different countries of the HTA system, including the process and also anything any case study that that could be relevant to the Indonesia HTA that is implementing at the moment. Before I start into the detail of the case study today, I will start off with a quick recap in terms of the HTA definition and then also the challenge that I observed from around the world related to the implementation of HTA, including or overcome it. And then we'll also move on to the case study, which I also selected around 5 case studies that found that could be relevant to the situation in the Indonesia as a food for thought for all the audience today. Slide. Next slide, please. Okay, so let me begin with the definition, a quick recap on the definition of the HTA. So HTA is actually a form of policy research that systematically examines the intervention and the consequence of the intervention that interests and also require the multidisciplinary knowledge, including the various stakeholders from the various perspectives to evaluate the certain health technology and ensuring that the outcome will be highest benefit to the patient. So as you can see, HTA process is definitely a complex and also involved with the potential challenge when we are going to implement. Next slide, please. So HTA process can be largely categorized into separate into 2 main processes. So the first phase related to evidence synthesis. So the evidence synthesis can be synthesized by within the STA agency or their relevant delegate, or otherwise in some country also allow manufacturers or delegate to submit the evidence to review as well. The type of evidence that involved in the STA process, firstly, of course, clinical evidence. Usually, STA will require the view of the clinical comparative effectiveness and also safety. And the evidence often came from systematic literature review or meta-analysis, or as well as sometimes also involved with the real-world evidence as well to show the real-world aspect of the certain health technology and also the disease characteristics and treatment landscape. And also another one that is very important as part of the consideration of the STA is the economic value. So most of the time, STA will also require the view of the value for the money. Therefore, the evidence related to economic evaluation study, such as cost effectiveness analysis or cost utility analysis, and also budget impact analysis are become very important as part of the STA process. Also, in some countries, and most of the time, they also have other considerations as well, such as equity, ethics, and also societal value. Some countries may also request for the certain research to allow this evidence to be part of the consideration as well. After we have obtained the evidence, then we move on to evidence appraisal. The evidence appraisal is a process that the STA agency will review and also critically appraise the submitted or consolidated evidence that was conducted in the earlier stage, and then also use that as consideration to inform and also evaluate the appropriate pricing and reimbursement recommendation to the policymaker and payer. The decision of the STA the conclusion of the STA usually can be recommended with condition or restriction, or sometimes not recommended. Next slide, please. As you can see that there are many times the implementation of the STA would be very challenging. The way to address the challenge of STA implementation therefore require a multidisciplinary approach. Here are some of the observations that I see in the globally on how they on different countries how they implement to overcome the challenge to help improve patient access, which is ultimate outcome of the STA process. The first one that I would like to highlight here is a stakeholder collaboration, which is also one of the most important steps. I see the example of Taiwan would be one of the good case study to show the to represent the stakeholder collaboration. So which I also going to highlight in my later presentation of the case study as well. To implement successful STA process, we definitely need a strong collaboration from all forms of relevant stakeholders, not just only from the policymaker alone, also include other stakeholders like industry or patient as well. That could be help to ensure the collaboration and include all the perspective. But the method is also one of the important process to be considered on how we can incorporate the patient's perspective or other stakeholder to be part of the STA process. The next one that I would like to highlight is also, and also I think is also very crucial as well, is a capability building. I think it is important, especially for the early implementing STA country, how they're going to ensure the capability and researcher and experts in the country. Funding for STA training would be important and also will help improving the capability in that country. Also collaborating and exchange knowledge from the international organization or other STA will also be helpful, which I think I can see from the HITAP in Thailand would be a good representative in this aspect. The next one would be transparent and rigorous process. To implement STA effectively, there must be a transparent process, which also will be essential to ensuring the patient have effective treatment in a timely manner and also allow the trust in the healthcare system as well. The next one would be the data infrastructure development, because STA also relies so much on the data, therefore the data infrastructure development would be very helpful, which I also observed that is already in the process in Indonesia as well, whereby Indonesia also established the National Claim Database or JKM database, which also allow the researcher to access data to conduct the real world study and also ensuring the outcome that reflect the country context. Another one is also spatial funding. Spatial funding also observed in many countries, in many STA countries, such as in UK, in the Kingdom, or including Australia as well. Many times the implementation of the STA may also be another barrier to that couldn't allow access to the treatment in timely manner, especially some of the high cost drugs such as cancer treatment. Therefore, having the spatial funding would be one of the approach that could help allow patients to access to the treatment in a timely manner, which I also include one of the case study in my later presentation as well. And finally, I think the process would be considered adaptive STA process when we are not very much ready in terms of the capability or other perspective. So adaptive STA process also allow flexibility to for the policymaker or STA agency to evaluate and assess the value of the treatment in a timely manner, which I also include in the next slide to explain for the definition of the adaptive STA process. Next slide, please. In the adaptive STA process that I observed in the publication, this is one of the publications that I came across, published by NEMSOF in 2023, which I think is also explain very interesting definition of the adaptive STA that is happening around the world. So I won't go to in all the detail of each category or each type of STA, adaptive STA definition, but I will just mentioning that adaptive STA is also by definition is a structured approach that allow optimal STA analysis and also the process to adjusting the analytical time, data capacity, and source of conduct in a timely manner. And it also address some of the challenge that happening in the different circumstances in the different country. In the paper, they also lastly categorize and observe different countries have different categories. Firstly, they call de facto STA, rapid review, rapid CEA, or cost effectiveness analysis, manufacturer-led submission, and also transfer. So these different categories also are still sitting at definition of the adaptive STA process and also allow the flexibility of the process and review time to ensure the timely access of the technology. In the next slide, I will just go through with some of the selected case study that is also, I analyzed that it would be relevant to each category, that could be relevant to each category that published in this paper as well. Next slide, please. So the first case study, I would like to highlight the process in Philippines. The Philippines also, in my personal view, I also feel that in the Philippines also in the similar stage and milestone like in Indonesia as well. They early adopting the STA, implementing the STA, and in that process, I already view this already adopt the adaptive STA process, which also allow them to address the urgent need of effective healthcare decision making, whereby also helping them to improve the capability building as well. In the STA process in the Philippines also can categorize into two options. The first option is focusing on clinical appraisal alone, whereby they will just appraise the whole dossier that's submitted for the complete assessment, and also including the submitted by the proponents, including the evidence related to the clinical, economics, ethical, legal, and social and healthcare system impact. So this process, this option will take shorter time, whereby in the second option will also require more comprehensive process, which is also the assessment team will also conduct its own assessment by themselves or their delegate, and then this can be combined with the various type of evidence, largely also starting off the clinical analysis and also cost analysis. For the clinical analysis, they also include the critical appraisal of the clinical evidence or systematic literature review or meta-analysis of the clinical evidence, and then also combined with the cost analysis, which could be a cost minimization analysis, budget impact analysis, and they also cost effectiveness analysis or cost utility analysis along with budget impact analysis. And also to highlight as well that in the Philippines, they also include the research that is called ELSI, which stands for Ethical, Legal, Social Impact, and also Health System Implication as part of their consideration as well. The option 2 definitely will take longer time, when this also depends on how the HTA agency will view which intervention would be more relevant to be part of the option 1 or option 2. Next slide, please. I think another classic case that I would like to highlight is also in Taiwan. This is also related to the data infrastructure and also transparent in terms of the process. We do know that they also have cancer immuno-oncology available in the market. Many of them also show a very promising clinical outcome to the patient. But in the reality is that many of the decision making still rely on the phase 2 study, which may not be mature enough. In the healthcare system of Taiwan, they do also have the National Health Insurance, which is also consists of all the treatment that they evaluate could be potential benefit based on the clinical outcome and also budget. But at the same time, they do aware that the decision making of immuno-oncology will be still involve a lot of uncertainty because of data is still in the early stage. Therefore, they decide that when they decide to implement to allow the access to the immuno-oncology for the 8 cancer type during that time, including 11 indications. So they already decided in 2016, and it's also help allowing more than 3,200 patients to have access to the medicine. But at the same time, they also implement the registry of the oncology or immuno-oncology. So all the physicians, they also have to record the outcome of the patient and also the treatment that already prescribed to the patients. And then this is also considered as a real world data as well. And thereafter, this data has been, after they collected after 1 year, 2 years, they also consolidate all the data to process for the analysis. And then they later also demonstrate the result, whether the treatment itself is considered value for the money or not, and whether the decision that has been made earlier also appropriate or not. So this is also a good example of having an established real-world data infrastructure in the country, and also allowing the re-evaluate process to ensuring that the early treatment or early access for patients to access to the treatment in a timely manner would also in line with the decision in the real world circumstance, also in line with the evidence that submit or decide at the earlier stage or not. I think this would be one of the good example that is also happened in Taiwan. Next slide, please. Another case study, I also want to highlight the procedure or medical technology that accessed in the United Kingdom or NHS. So this case study also found in the publication as well, and also has been selected by INA-HTA member that is also considered as a very interesting case study. So in the background of this case study, the treatment is also benign prostatic hypertension, hyperplasia or BPH, which also cause a lot of impact in terms of quality of life, in terms of lower urinary tract symptom, impact to quality of life of patients. NICE, which is a HTA agency in the UK, they already conduct the comprehensive research and already give the recommendation that minimally invasive procedure is considered appropriate and cost-effective treatment option and should be an alternative treatment to the traditional surgery. However, despite the clinical benefit, initial uptake was really low. came from limited awareness among all the clinicians, and also most importantly about the budget constraint at the local NHS trust. And also, they also have an uncertainty in terms of the data related to cost effectiveness and in the real world setting as well. The action that has been taken by the NHS is that they also implement the special funding scheme. So NHS England also introduced commissioning through evaluation or CTE, and later also innovation and technology payment or ITP program, which also allow the coverage of the procedure cost for the early adopter, and also will help reduce the risk, financial risk at the hospital level. Also, in the implementation process, they also adopt the implementation support, which is nice. Develop the guidance of the document related and also costing template, and also adopting tool to allow the access to the clinician to help them when they evaluate, they adopt the minimal procedure, minimal invasive procedure. Also, finally, they also allow more stakeholder engagement, giving more education, webinar, workshop to the relevant stakeholder to raise awareness of this treatment choice, and also seek for collaboration for professional society and patient advocacy group as well. Finally, the impact of all these implementation also taken off, and also see that significant increase in uptake across NHS trust, also help improving patient access of the less invasive treatment option, improve quality of life as well, and also demonstrate how HTA funding also can accelerate adoption. So I think this is also a good takeaway for Indonesia perspective as well, that when we implement the treatment, especially for the procedure or medical technology that requires some investment, special funding could be one of the consideration to ensure that later on there won't be a barrier for the access to the effective treatment. Next slide, please. And this is a case study that IQVIA also have proudly part of the process as well. There was it happened in Malaysia related to the rheumatoid arthritis, where IQVIA was part of the researcher who conduct the cost-benefit analysis. The background of the case study also because rheumatoid arthritis is also considered very highly burdened disease in the society, and also involved with a lot of morbidity and long-term disability. Although they already have the effective treatment or biological treatment available, but the access to the treatment is still very limited. There is a treatment option available in the Ministry of Health listing, but the access is still very limited to only about 5%, which is for the advanced treatment of the rheumatoid arthritis. This is because of the budget allocation. So the solution that is happened that the sponsor during that time also working with us to conduct the cost-benefit analysis. The IQVIA team also conduct the cost-benefit analysis, which is not only focusing alone for the sponsored product, but include all the advanced therapy that is available in Malaysia. So the cost-benefit analysis will also enable the assessment of the financial requirement to help improving the current access of the advanced rheumatoid arthritis treatment among those eligible patients, and also examine the potential health system saving as well as any other potential indirect benefit resulting to the improve of the disease control. The outcome is also very positive, because later on, as part of the result, also part of that process as well, the sponsor also use the result and publication. This is also the result is also published in the peer-reviewed journal, and later the result also presented and engaged and demonstrated to the Ministry of Health in Malaysia to show the benefit of the appropriate access to advanced therapy, and it's also eventually resulted to the more access to the advanced therapy and more budget allocation, which is also help showing improving patient access to advanced treatment for rheumatoid arthritis. And also in the long run, MO is also aware that this could help potential long-term saving based on the evidence that provide and as part of their decision-making process. Next slide, please. And the last case study I would like to highlight here is also came from Taiwan as well. I think some of as may be also aware that in Taiwan, as part of the national health insurance process, they already incorporate patient voice into the SDA process, which also could be a critical step in the second generation of National Health Insurance Administration. So patient or caregiver already they are invited via the website to be part of the HTA process or the review of the reimbursement for the pharmaceutical benefit scheme in Taiwan. And they also, the representative can also join and observe, or they can also, during that time, they may be able to give some comment, but they may not be the right to vote the decision. So this is also demonstrate the benefit of incorporating the patient perspective and patient voice, which also going to be that they are also part of the important stakeholder and also the benefit, the beneficiary for the decision making. However, I also would like to highlight that there could be a challenge as well, because the process of gathering patient input also still take some time, and also need a lot to ensure that the comment will be also fairly taken and also incorporate in how it's going to be incorporated into the process would be another consideration for the HTA implementation in any country as well. Next slide, please. So in conclusion, the implementation of HTA is definitely crucial for ensuring patients they will be able to access to the best possible health care. So, but building to the sustainable HTA framework and process definitely require a careful consideration to ensure that it will not become another barrier for patient access. While there is no perfect method or there is no one-size-fits-all, I think various approaches such as implementing adaptive HTA, ensuring stakeholder collaboration, and also transparent process could be considered for a sustainable system that will help unleashing patient access and also lead to the ultimate goal of improving patient well-being. That would be all for my presentation today. I will hand over to next speaker. Thank you.
Thank you, Sirin. Good morning, everybody. It's a great pleasure for me to be here and to, on behalf of the Indonesian Health Technology Assessment Committee, to present you an overview of the landscape of health technology assessment in Indonesia. Next slide, please. Next slide. Several important disclaimer, but I would like to point you to number 3. So what I'm going to present you today will be an update information as of today, but please be mindful the majority of what I'm going to convey here are a very active policy discussion topics. So it's subject to be updated and even probably frequent revisions. So please be mindful of that, but I can assure you that I'm going to present the most updated information as of today. So next slide, please. So let me start with next slide with a very brief overview of the contextual background that leads to the advancement of HTA in Indonesia. Next 2 slides, please. So as you know, that Indonesia is undergoing this what's the so-called epidemiologic transition from mainly infectious disease to mostly non-infectious disease, or what Omran call as the man-made disease. So by 2040, I think it's expected that 7 out of the top 10 top disease burden will be contributed by non-infectious diseases, including heart disease and cancer and other diseases, and even tuberculosis. Indonesia is now ranked number 2 globally. In 20 years, it is expected that the tuberculosis burden will be ranked number 9, just below several non-infectious diseases. And consequently, we also observe an increase in health expenditure. So for the past 10 years, these graphs shows you total health expenditures from 2014, the year that we started the national health insurance, So we can see a constant increase of 9% annual increase in total health expenditure. But if you pay attention to the red part of the bars, that shows the JKN expenditures that grew for about 350% in its first 10 years of implementation. So understandably, we need to have a process that can ensure the efficient and effective use of fundings, considering all these increasing disease burden, and also not to mention the introduction of new technologies. So next slide, please. And for that purpose, we have the health technology assessment. So we know health technology assessment as a scientific approach, but what I'd like to convey here is that Indonesia recognized HTA as a policy tool. So it's backed by the presidential regulation in 2018 that requires the use of HTA as a quality control and cost control for the JKN. JKN is the National Health Insurance. I will refer that to as JKN from this point. So that is a part of the a mandatory procedure for any new technologies. By technologies, as Sirin mentioned, that includes medicine and all other things, including health policy, health programs, to undergo health technology assessment. But especially for those technologies that are to be covered by the JKN. And for as an additional regulation that support this presidential regulation, we already have national guidelines on the HTA conduct, and we're developing several more guidelines to include more adaptive processes, more innovative processes. And again, I'm saying that this is a very active methodological and policy discussion. And of course, we're looking forward for inputs from all the stakeholders involved in HTA. And we also have this committee for health technology assessment, who is responsible for the daily conduct of HTA with regards or in relation to JKN and national health programs implementation. So next slide. Now, we all know this, but I would like to underscore the other aspects things. So HTA is a systematic evaluation. It's a systematic approach to evaluate health technologies. And I think we understand that cost effectiveness evaluation and budget impact evaluation, economic evaluation plays a major role in HTA, but by no means they are the only assessment, they're the only perspective that are used in HTA in Indonesia. We also concerned about equity. We also are concerned about legal and ethical issues. So while the economic evaluation part still plays a major part in the health technology assessment, these other topics, these legal, ethical consideration and equity consideration will also come up during the discussion, during the appraisal by the committee. So I think that we need to take that into account as well. To say that the cost effectiveness is necessary but not sufficient for implementation in the national program, including JKN. Although I have to mention that we do have a structured and systematic approach. We have guidelines on conducting economic evaluation, but I think we are still lacking on formal and structured approach in taking into account these other considerations. So I think this will be also included in the active policy and methodological discussions in Indonesia. So next slide. This one is a mandatory slide. If you have attended Ministry of Health presentation, you probably have memorized this health transformation house. I would like to say that HTA plays a very central and important part in the health transformation efforts. And I would like to direct you to the low left corner of the house where we have this transformation of the health financing system. So the goal of the transformation will be to make available, sustainable, fair allocation and effective and efficient use of medical technology and health finance and money. And that's where HTA plays a very important part. So HTA has been a very active part in the health transformation. And we can see that, next slide, please. Next again. In its evolution, HTA was born at the same time of JKN, not born by born, I mean as a policy, as a matter of policy. So ever since we have JKN, we also have the necessity to conduct HTA. But in the past 10 years, a lot of things happened, a lot of development and very positive development occurred in just the past 4 years, just right after the pandemic. So if you see in 2021 there in the timeline, we launched the health system transformation. So the next year, in 2022, we had the revised HTA guideline. The next year, in 2023, the Ministry of Health initiated the review of HTA business process and start to discuss about how to improve and develop new business process that would allow a more expedited HTA processes and hence can produce more recommendation in a relatively shorter time. So for the time before 2021, so the 2021-2022, that marks a very a turning point for HTA in Indonesia. So before those years, since 2014 to 2022, all the HTA evaluation, the assessment done in Indonesia was done by means of a full HTA process, economic evaluation that fully use primary data sources. And since 2023, we all started to think about a more adaptive processes that can make the best use of available data and improve the efficiency of fundings. Because we have to be honest, we don't have that much funding to conduct HTA, require HTA for that numerous new health technologies, medicines, and technologies that can be useful for Indonesia. So next slide, please. So this is a good news. Well, I hope you can see the good news here because since 2015, we had done 51 HTA studies. So on average, only 5 per year. So that's probably not the good news. But the good news is that 50% of these 51 HTA studies were done or are currently being done in the past 2 years alone. So ever since the reformation, ever since the adoption of new adaptive processes, we can accommodate more number of studies, more number of topics to be assessed and potentially to be recommended to the national program. And for those 29 who had produced recommendations, they had been implemented in various policy venues, including FORNAS, that had direct consequence on to GKN financing, but not only FORNAS, it also PNPK, that is the standard clinical pathway, tariff adjustment, and also other national non-JKN national programs. So I think the good news is that in the past 2 years, we can accommodate more topics to be assessed by the committee and by its agents. So what is the committee? Next slide. So in doing HTA, we have this HTA committee. Next slide, please. That is a semi-independent body. The previous slide. Yes, so HTA committee is a very important committee, which I'm a part of. So it's a semi-independent body led currently by Professor Aulia Sufuantika from Universitas Pajajaran. So the health minister serves as the advisor, and we also have the advisory board that consists of director generals in the Ministry of Health. But the chairperson and the members of the HTA, the National HTA Committee, are taken from academics and clinicians, hospitals, And when we require staff of the Ministry of Health, they will serve the committee as an ex officio capacity. So since 2014, we already had 4 different committees. The first 3 were chaired by clinicians, and now our current committee is chaired by pharmacist, Professor Aulia. And now for the red box there, that's a major development, major restructuring in the committee structure. That, as Sirin mentioned, the health technology can be defined as medicinal products and many other things. So under the committee, we have 2 subcommittees. So one subcommittee dealing with medicinal products, and one subcommittee dealing with all those other things. So health, medical technologies, including health program, and so on and so forth. But we have 2 separate subcommittees for that. So next one. In total, we have 28 members in the national HTA committees. And we have pictures and names of those members. So you are officially introduced to the members of HTA committee. Please say hi if you meet any of us anywhere. Next slide, please. Now, this is a very important slide that shows you 4 major development in HTA processes in Indonesia. So some of which had been mentioned by Ibu Rizka and Pak Asnawi in their opening remarks. But maybe we can go over slightly more details in the following slides. But just to mention briefly, the first one is the use of one door, one standard HTA. So at least we aspire to have a single door entry point where every proposal for HTA assessment will go through just this one single door. Of course, it has a couple of windows, which is the regular pathway, which I will talk about with more detail later, and the stakeholder-led submission. I think this is a very interesting development and a very exciting development for Indonesia, that now we are starting the policy process to enable stakeholders to submit their own results, and those will allow the committee just to appraise, not to initiate the studies on our own. And the third development will be the adoption of new assessment methodologies. As I have mentioned, in the past, we used full HTA method that will require a lot of time to finish. And now we are moving to a more adaptive and rapid assessment methods. And lastly, we also include this value-based pricing approach. So not only that HTA can be used to assess whether a technology is cost effective, but we can also allow manufacturers or other stakeholders to offer different price points such that we can end up with a more acceptable results, and that can increase the probability of acceptance as a recommended, or for example, in JKN benefit package. So next slide, please. So one door, one standard. So this is an aspiration. Please note that this is also an active policy discussion. So we are heading this way, but please do understand that we are in a transition period. So we will see some differences in the idea here that we want to have one door, one standard, where all proposal will go through this one integrated website. So you can all propose that to the same process, and all proposal will go through the same standard processes and assessment criteria. But maybe for now, during the transition period, we will still have some aspect of the previous national formulary process, and in addition to the HTA process. And for those standards, we have developed we have updated the national guideline for HTA, and we are now developing, I think, to my knowledge, 3 additional guideline or reference cases for the different adaptive HTA methods, as well as a guideline for measuring quality of life. Especially that now we are adopting these adaptive methods, we are relying more and more on secondary data sources. So that's the 1.1 standard policy. Next slide. So briefly, just for your information, I think we can discuss this more, and you can always reach out to the committee or the secretariat for more detailed information on this process. We have this lengthy process, but hopefully they're not lengthy, but well, they're numerous, but hopefully they're not that lengthy. So we collect topics, and then we end up with conducting the prioritization of topics. So all of these are done by the HTA committee, supported by the secretariat. So next slide. So this one is also very important for the audience here. So the two different processes for HTA. The first one, the top one, will be the regular submission process, and the bottom one, it will be the SLS, the stakeholder-led submission mechanism. So to refer to Siren's presentation, I think in the regular submission process, the HTA committee, assisted by the HTA agents distributed in several universities in Indonesia, will do the evidence synthesis and the evidence appraisal. So the regular process starts with topic submission. So I will show you the different stakeholders that can propose topics, and the HTA committee will select those topics, and those selected will be assigned to the HTA agents for them to start the evidence synthesis, and then the HTA agents will submit the evidence to HTA committee for appraisal. But for the second mechanism, the stakeholder-led submission, this is meant to expedite the process. But what is expected to happen is the stakeholder will do their own HTA assessment. They will do their own economic evaluation and submit the results to the HTA committee. So in SLS mechanism, the evidence synthesis is expected to be done by the proponents, and the HTA committee will then appraise the evidence, and that in doing the appraisal, the committee can be assisted by HTA agents. So we project that the SLS mechanism can be open, can be launched by next year. Hopefully it will be launched next year. We're trying very hard. So at this point, just for your information, we had piloted the mechanism. So a revised SLS guideline is currently undergoing. So the secretariat and helped by the experts is now revising the already piloted guideline. So hopefully once the guidelines are ready, we can start the SLS process. So next slide. Just to say that, again, I already told you this, that in the past we conduct full HTA that can take up to 20 months. It's a very lengthy process because we had to collect primary data and find patients that often not that many, especially we talk about innovative drugs, cancer drugs, and that was not funded by JKN. So logically, there were very few patients. So now we are moving to adaptive HTA that can hopefully take shorter time to finish. Next slide, please. I think I will skip this one. This is too technical. Yeah, so again, in conducting HTA, the committee does not do the assessment, does not do the evidence synthesis. We are responsible to ensure the process is going. But when it comes to evidence synthesis, we are helped, we are assisted by agents. So for now, we have, I think, 8 universities. So this is last year information. We have 7 universities plus 1 HTA hospital team that conducts HTA. And also be mindful that within a university, they may have more than one HTA team or one agent. But of course, in the past, we only had 2 or 3 topics a year. Now we have 25 in 2 years. So obviously that means we are open and we're expecting that more and more universities or research institutions to be more actively involved in doing HTA. So I think this is an open invitation for you to become an active part of HTA in Indonesia. And next slide. So lastly, once the evidence is synthesized, the HTA will appraise the evidence, and again, the appraisal outputs can be accept or reject. I think most of the time is accept with revisions, with numerous revisions, and once the evidence is accepted, the HTA committee will deliberate to produce a recommendation for the health minister, and the minister will then decide what kind of recommendation that he will produce. Okay, last few slides. So again, next slide, please. So Sirin already mentioned this, one of the things that we need badly in Indonesia is data, because, well, I think we all know the condition that it's very hard to get data. Well, so what we'd like to encourage the stakeholder is that, well, considering the health technology life cycle, I think we invite all of you to think about how to produce data for Indonesia, like locally appropriate, contextually appropriate data during the whole life cycle of your technology. So that include during the preclinical phases and clinical testing phases, but not limited to those phases, also during and after the marketing of the products. And hopefully, if we can have this data since the testing phase, we can encourage a more expedited registration, whereby the manufacturer can submit registration at the same time as the HTA process. So hopefully, if that happens, and if the evidence shows or support the adoption of the technology, by the time the technology is registered, it can be also as soon as possible included in the national program and JKN. Hopefully, that's the aspiration again. Next. So these are different stakeholders that can be involved in the HTA process. You see, and the columns there show the various process steps of HTA process in Indonesia, starting from topic proposal to monitoring. And as you can see, anyone can propose HTA topics that range from the HTA committee themselves, the Ministry of Health, BPJS Kesehatan, professional organization, the industry, even patient groups can propose topics. If you have the capacity, of course, you can also do the HTA study. That's in the middle columns. So all stakeholders can provide data, and if you have the capacity to do HTA, you can also do the HTA study. So that's fine. Of course, we have these guidelines, we have these standards. We want this as scientific and as robust as possible. And also, everyone can be involved in assessment, and some stakeholders will be involved in more steps in compared to other stakeholders, of course. So lastly, the key messages. The first one is that Indonesia recognize the use of HTA as a systematic and transparent process to help the government making evidence-informed decision making. We want to enhance, we want to increase the efficiency, taking into account fairness in patient access to high quality and innovative medical care and technologies. So obviously, technology with significant value for money, with higher cost effectiveness, will be more likely to be included in benefit package and in government program. But of course, taking into account affordability, because, well, we have so much money in our pockets to finance all the health needs. And of course, data availability is still a challenge. So we encourage all stakeholders, everyone, to try and help us think about how to make data more available, and to borrow Sirin's terminology, to enable us to use real-world data and produce real-world evidence. I think that's a big challenge, but we also need to think about and move forward to ensure that we can have those data. And lastly, we are willing to learn. That means everything is subject for revision and improvement. And of course, we need your support, because without the stakeholders' support, I think we cannot learn as fast as we want to. By that, I conclude my presentation. Thank you, and back to you, Pak Joel.
Okay. Thanks a lot, Dr. Professor Panji. I think, I look at this discussion that you have, and I think I want to congratulate you. First, it's a complicated process, but you managed to, I think, give us, a good way of getting the essence of what this new process has entailed. Now, I will not ask the same question, over the review and assessment process. What has taken you to that process? It looks, well thought of. But I know you mentioned that it's really bridging the science and the policy. Right? So we have several questions from our audience, and thank you very much, our dear audience, for all these questions. There's a lot. We're seeing it. It means that we are very much involved. Thank you very much. In the interest of time, we are not able to get through all of this, but we promise to get back to you. We have all the list. So we'll just shoot to our two speakers what we feel are, at least what we can take on in the next few minutes. So bear with us. So I'll go first with you, Prof. Panji. Right. I've been in Indonesia for a while. I see really very, very good way on visualizing and planning through it. If you look at all the questions from the audience, most of them would be looking at the questions on execution and implementation, right? So there are like 4 or 5 questions that I've seen on this question. So in the implementation side, Prof. Panji, where do you see the plus and minus on this? Where do you see the challenge, and where do you see the support needed?
That's a great question. So I think the first thing that came to mind is that human resources, it's HTA, especially when we talk about doing economic evaluation, pharmacoeconomic modeling. I think we found that human resource for that is really scarce. So that explains why we only have 8 universities involved as our agents. Because although I'm sure there are people out there who can do pharmacoeconomic modelings, but I think that's the first thing, that we are lacking competent human resources, especially in the context of doing HTA for policymaking. Because it's answering policy question is a completely different animal to answering pure research questions. Right? So I think that's one thing. And of course, the second thing that I can think of will be data availability. Because I think we learned by experience that it's very hard to obtain the required data to populate the models. Especially, costing we can do. But then when it comes to measuring clinical effectiveness from real-world data, it's very, very, very hard. And that's one. So, and of course that came from different sources. The one is the number of patients may be limited, especially again if we talk about new innovative technology with very few users because they're not funded by JKN, so it's very hard to get patients. And of course, in Indonesia, considering the scarce resource, sometimes the implementation of technology differs from what we aspire it to be. So there's some deviation from standards and clinical guidelines because clinicians here, not in a malicious way. As a matter of fact, the exact opposite. They want to provide bigger access, more access to more patients. So sometimes they cannot implement the technology or provide the medication as it was intended because otherwise fewer people would get access to that. So I think there's a lot of implementation problems. Yes, of course, I have to admit that it will be a lie if I say no, we're doing good, where implementation is perfect. No, but I think in our experience, I think we have a lot of supports from the clinicians and a lot of supports from the various stakeholders, and they're very willing to help providing data and providing access to information that we require to do HTA.
Okay, very good. I think I don't want to leave that topic yet because I'll go to Serene, but there would be a follow-up question on
Yes,
that
please.
discussion.
Yes,
but I don't want to
Bajo.
leave the topic on the execution side. And you spoke about, of course, data. Finding those evidence, and that's of course very close to what we do in IQVIA. But I think I would like to ask you, Serene, maybe you would like to comment from that implementation challenge from the point of view on data, and given your experience and the work that you have done across the markets, what would be your recommendation? That's one. The other question that I've seen in the board is on the different considerations or factors affecting HTA, and one of them would be with regards to patient preference and the patient's involvement in general. So I think let's comment on that too first. If we have some more time, then we will probably expand on probably one or two more topics. Serene?
Thanks, Joel. And also very impressed with Dr. Panji when you shared about the process in HTA in Indonesia, which is, I think, currently what I personally observe and also view for Indonesia HTA is also in the very critical milestone. Of course, this is a challenge that the implementation part is one of the most challenging process and step in many of the country when you're implementing. But in Indonesia, at least you open for collaboration and also try to implement it in the transparency approach, which is also going to be helpful. I think in most of the country where we are right now is also similar situation as well, where we have really limited capacity and capability in the country. Not many researchers also know how to conduct economic evaluation, for example. Back to the time that when I entered to this area in health economic outcome research 10 years plus, in Thailand also similar as well. Only a few people who know how to do it. But continuously, I also see that involve a lot of various stakeholders in the university or even HTA, like HITEC, for example, MOH, for example. They continuously giving the budget allocation to invest in terms of knowledge, sending students, giving their scholarship for study, which also allow them to learn from other country, for example, and then they come back and then they also share their experience and expertise, which also help in terms of contributing in terms of the capability and capacity building in the country as well. And of course, open for collaboration and open for stakeholder involvement would be another helpful approach, because you also can feel some contribution from manufacturer, for example, or third party, for example, or even university, for example. That would help in terms of ensuring that the information, because in principle of HTA, in the principle is we want to ensure that the decision making of healthcare also inform with the evidence, right? And ultimately will help improving patient access and improving patient health outcome. That is the ultimate goal. So therefore, allowing contribution from various stakeholders definitely will be helpful into that perspective as well. I think another thing that I also want to highlight here also the data, right? Because data is also one of the crucial things. And I also see that in Indonesia also implementing like JKN database, BPJS database that also allow researchers to access and use the data and I also see the continuous improvement over time as well. Over the past like 7-8 years ago when I came to know that BPJS also have data that can be conducted as a research. Later on also see that, they also allow some initial access from the like general population. The general researcher can also access, also allow, have a prior process to access to the data, which also help representing and reflecting the country real world circumstance of the country and also more relevant comparing to using the data outside the country. This is also one of the good milestones. Of course, like moving forward, we can also view the country like Korea, for example, where they also implement HeLa database and also allow researchers to access and use it for consideration and affect the country.
Thanks, Serene. I think that really captures, the well, from other markets. You're saying it's not very different. The challenges are there, data, but you also talk about what we are able to focus in terms of what needs to be considered to progress. So those are key points, Serene. So we'll, as I've said, in the interest of time, right? We'll probably throw the final question to you, Prof. Panji. But before that question, I heard from Prof. Panji, because he's beside me, on the implementation timeline. So you're saying this will be by next year, is it right?
So the SLS, the stakeholder-led submission.
Okay. So that's good. I think a lot of
we would like it to happen this year, but this is already November.
Okay, so that seems to be a more realistic now. I think the final question now, because Serene also mentioned about BPJS, their involvement, right? Where do you see the involvement of BPJS coming more effective into the process? One stop, one door, all this new process. Where do you see it really becoming relevant?
Yeah. Okay. Thank you, Joel. That's a very good and important question. So I think, as I already show in one of my slides, that BPJS can actively participate as a topic proponents, so they can propose topics. I don't think that had been done, but they can. And then they, of course, are very crucial in providing data and information. If they want to, they can do HTA studies on their own. And they can also serve doing the assessment, and lastly, they implement the recommendation. So I think what I need to underscore here is that the HTA is a part of a process under the Ministry of Health, and the final product will be a recommendation to the health minister, and the health minister will then conclude and recommend whether a technology is to be covered in JKN benefit package or not, or other health programs. So in that sense, BPJS is an implementer. And of course, yeah, in our experience, BPJS is always actively involved in the discussion because especially when during the assessment and sometimes they also we need their opinion and on the budget impact analysis because we do the budget impact analysis for BPJS, so we need to know what they think about the scenario. So they're actively involved as well in discussing the methodology by which we use in conducting, especially the budget impact analysis.
Okay. So that's very good. Thanks, Prof. We'll we'll I think go back to the audience. I keep mentioning because at this time we're still seeing more questions. So we'll I think wrap up from here. Thank you to our audience, of course, who has been time your time. Let me just try to leave away with a few key takeaways from today's webinar. So you've heard both speakers. We've heard the role of HTA, what's the best practice in other markets, and some recommendations. Similarly, you've heard Prof. Panji try to break down a somewhat serious and complicated topic, breaking it down to us in a more manageable way, but very, very insightful. Well, in the end, I think we would like to look at HTA not only as a strategic tool to balance innovation and cost effectiveness, but more importantly, helping out in capacity building, data systems, and stakeholder collaboration. What's next for Indonesia, and probably what is the future direction that we see not only in Indonesia but also in other markets? I think there are three things. Number one is to strengthen the technical guideline, and this talks about reference cases. The second key point is encouraging collaboration, and I think we've heard our speakers talk about this a lot. Among the different stakeholders, MOH, academia, industry, BPJS, right? And finally, of course, we wanted more data infrastructure and transparency and capacity building. And with that future direction, I think this will not hopefully be the first and the last. We're seeing this as a very important and relevant topic, not only in Indonesia, in the region. And again, we in IQVIA, we are very fortunate, and we're glad to be a part of this session and the next. So thank you very much. We are closing the session. Terima kasih banyak.